Welcome to Dr. Mrs. Saeed. Today's our topic is about ectopic pregnancy. So now we talk about first essentials of diagnosis. Amenorrhea or maybe irregular bleeding and spotting. Pelvic pain, usually adnexal. Adnexal mass by clinical examination or ultrasound. Failure of serum beta acidity to double every 48 hours. No intrauterine pregnancy on TVS transvaginal ultrasound with serum beta acidity greater than 2000 millunits per ml. Now we talk about journal consideration. Ectopic implantation occurs in approximately 2% of first trimester pregnancies. About 98% of ectopic pregnancies are tubal. Other sites of ectopic implantation are the peritoneum or abdominal viscera, the ovaries, and the cervix. Any condition that prevents or retards migration of the fertilized ovum to the uterus can predispose to an ectopic pregnancy, including a history of infertility, pelvic inflammatory disease, ruptured appendix, and tubal surgery. Combined intrauterine and extrauterine pregnancies, heterotopic, may occur rarely. In the US, undiagnosed or undetected ectopic pregnancy is one of the most common cause of maternal death during the first trimester. Now we talk about clinical findings, means signs and symptoms. Severe lower quadrant pain occurs in almost every cases. It is sudden in onset, stabbing, intermittent, and does not radiate. Backache may be present during attacks. Shock occurs in about 10%, often after pelvic examination. At least two-thirds of patients give a history of abnormal menstruation. Many have been infertile. Blood may leak from the tubal ampulla over a period of days, and considerable blood may accumulate in the peritoneum. Slight but persistent vaginal spotting is usually reported, and a pelvic mass may be palpated. Abdominal distension and mild paralytic ileus are often present. Now we talk about laboratory findings. The CBC may show anemia and slight leukocytosis. Urine PT positive, and if beta acidity occur, so it also positive. But there may be a slow rise of beta acidity doubling every 2 days associated with normal earlier intrauterine pregnancy or the falling levels that occur with spontaneous abortion. A progesterone level can also be measured to assess the viability to the pregnancy. Number C is imaging. Ultrasonography can reliably demonstrate a gestational sac 5 to 6 weeks from the last menstruation and a fetal pole at 6 weeks if located in the uterus. An empty uterine cavity raises a strong suspicion of extrauterine pregnancies, which can occasionally be revealed by transvaginal ultrasound (TVS). Specified levels of serum beta acidity have been reliably correlated with ultrasound findings of an intrauterine pregnancy. For example, a beta acidity level of 6500 millunits per ml with an empty uterine cavity by abdominal ultrasound is highly suspicious for an ectopic pregnancy. Similarly, a beta HCG value of 2000 milliunits per ml or more can be indicative of an ectopic pregnancy if no products of conceptions are detected within the uterine cavity by transvaginal ultrasound. Serum beta HCG levels can vary by laboratories. Number D. Special examination. Laparoscopy is the surgical procedure of choice both to confirm an ectopic pregnancy and in most cases to permit removal of the ectopic pregnancy without the need for exploratory laparotomy. Ectopic pregnancy should be suspected when post-abortal tissue examination fails to reveal chorionic villi. Steps must be taken for immediate diagnosis, including prompt microscopic tissue examination, ultrasonography, and serial beta HCG every 48 hours. Prognosis. Repeat tubal pregnancy occurs in about 10% of cases. This should not be regarded as a contraindication to future pregnancy, but the patient requires careful observation and early ultrasound confirmation of an intrauterine pregnancy. When to refer? When severe abdominal pain occur, palpitation of an adnexal mass on pelvic examination, abdominal pain and vaginal bleeding in a pregnant patient. Now we talk about when to admit. Presence of symptoms or sign of a ruptured ectopic pregnancy. So don't forget to subscribe our channel. Next time, next topic. Bye bye.